So you're welcome to this channel, and please, every time you watch this video, always remember to subscribe and put your comments so that we can see how we can improve on our videos. So today we want to talk about diabetes mellitus. Diabetes mellitus, and this diabetes mellitus we want to talk about is a metabolic syndrome, or what you can call it a metabolic disorder. It is a metabolic disorder. Metabolic disorder characterized by hyperglycemia, or characterized by increased blood sugar levels. Increased blood sugar levels greater than 11.1 millimoles per liter. Or in bracket, you can put 200 milligrams per deciliter. This is for random or postprandial, or it can be greater than 7.0 millimole per liter for fasting. For these 7, you can call them 126 milligrams per deciliter. That's how we can define diabetes mellitus. So it is a continuous, it's a metabolic disorder characterized by hyperglycemia, or increased blood sugar levels for postprandial that is greater than 11.1 millimoles per liter, or greater than 7 for fasting. As we know that we can use different blood samples to diagnose. So we can either use the fasting, or we can use the random, or what we call postprandial. 2-hour postprandial. That is after 2 hours of eating a carbohydrate meal. So this is what we can define as diabetes. And there are many different types of diabetes mellitus. So let us look at the types of diabetes mellitus, whereby the major types of diabetes mellitus is we have type 1. Diabetes mellitus type 1. Mellitus type 1. We have diabetes mellitus type 2. These are the major ones. Then others, we have gestational diabetes. Gestational diabetes mellitus. Also, we have others. Other types. Others, these ones are due to secondary. They are secondary to infection. Secondary to other disorders. Whereby this diabetes can be either due to Cushing's syndrome. Cushing's syndrome. It can be to insulinomas. It can be due to infections, which can trigger increase in sugar levels. It can even be due to Addison's disease. All of those ones can also cause this. Then also we shall see also another one called MODE, maturity onset diabetes of young. What we call MODE, if you have ever heard of it. But the major types is type 1 and type 2. So let us expound more on type 1 and type 2. As we have said, type 1 diabetes, this one in population, it covers 10%. If you have 100 patients, only 100% patients, only 10% can suffer from diabetes type 2, compared to type 2, whereby 90%, almost greater than 90% of the patients have type 2 diabetes. And we say that this type 1 diabetes mellitus is insulin dependent. It is insulin dependent. It is insulin dependent because why is that it is due to lack of insulin. It is due to complete, or you can use the word absolute. It's due to complete or absolute lack of insulin in the body. Why is the insulin not there? Why are we saying that is due to incomplete lack of insulin in the body? It is because it is caused by the autoantibodies. It is caused by autoantibodies, which are produced against beta cells. So these antibodies kill or destroy the beta cells which are responsible for production of insulin, leading to complete lack. So that's why we say it is 10% in the population, and we say it is insulin dependent. Why? Because to treat this patient we need to give insulin. Because the body is completely lacking insulin. So whenever they want to eat food, they must be injected with insulin. That's why you call it insulin-dependent diabetes mellitus. Insulin-dependent diabetes mellitus, and we are seeing it is an autoimmune disease. Autoimmune disease, whereby there is a production of autoantibodies which come and destroy beta cells. And we are saying in this condition, patients who have the diabetes type 1, they are prone to what we call DKA, diabetes ketoacidosis. So these with type 1, they are prone to DKA, what we call diabetes ketoacidosis. You can ask yourself, how does DKA come in type 1? Because there is complete lack of insulin, the acetyl-CoA which is formed is channeled into what we call ketogenesis. There is the formation of ketone bodies. We see formation of ketone bodies, and these ketone bodies, they are moderately acidic. And because they are moderately acidic, they deprive of bicarbonate reserves. So in the kidney we have there, in the blood we have what we call bicarbonate reserves. So they are depleted by these ketone bodies which are moderately acidic. And because we know bicarbonate is the one that is also helping us in maintaining the pH of the body. When bicarbonate reserves are depleted and they go below, this is greater, they go below 15 milliequivalent units or millimoles per liter, this one will result into DKA. So how does type 1 bring about diabetes ketoacidosis? Is that it triggers ketogenesis, that is the formation of ketone bodies, which are slightly acidic or moderately. So they go and combine with the bicarbonates, hence reducing. And you know acidosis, metabolic acidosis is reduced levels of bicarbonate. When you reduce levels of bicarbonate, that is what we call metabolic acidosis. So that's how type 1 we see this DKA coming in. So whenever you are in the laboratory and you do urinalysis, you find ketone bodies in urine of a diabetic patient with type 1, it is an emergency. Always handle that fast, because this one can result into coma and death, isn't it? Due to reduced anion gap. So that is how this guy can result into DKA. Then another one we can talk about, allow me to put it the other side, because this space is already taken up. So we have diabetes, this is type 1, diabetes mellitus type 2. So this type 2, we said it occurs in 90% of the patients. or is suffering from diabetes type 2, and this type 2 is due to what? It can be due to either reduced, what we call decreased levels of insulin, or it can be due to insulin resistance or insulin resistance. So the causes can either be due to decreased insulin, meaning the levels are low, or it can be due to resistance, whereby insulin is too much in the body. It is enough, but the cells are not responding to insulin. And this one, that's why you call it insulin independent. Insulin independent diabetes mellitus. It does not depend on insulin, because insulin is available, but the cause is that the body cells are not responding, or there is decreased levels. And maybe what I have forgotten to tell you here in type 1, it is early onset. Type 1 is early onset, or is below 14 years. It can even occur within 2 weeks after being born, but this is adult onset. Type 2 is adult onset. The major candidates are people greater than 40 years. When you are greater than 40 years, you are a good candidate of diabetes type 2. It is adult onset. Then another thing I can tell you about type 1 and type 2, this one we saw in type 1, there is diabetes ketoacidosis, isn't it? In type 2, there is no DKA. Instead, we see people with diabetes type 2 are going into what we call HHS, what we call hyperosmolar state. They go into what we call hyperosmolar state. Hyperglycemic, hyperosmolar. Hyperglycemic, hyperosmolar state, whereby there is increased blood fluid osmolarity. Because we see these ones, it can be brought about by either decrease in sodium, there is accumulation of the sodium ions in the tissue, but decreased in blood. So this one can lead into what we call the potassium and the sodium can go high, can be reduced, then leading to what we call hyperosmolar state. So in type 1, we see diabetes ketoacidosis. In type 2, it is hyperosmolar state. And this hyperosmolar state, that's why you find patients are having fasting. They want to drink water every time. This one leads to excessive thirst, what we call polydipsia. It can even result into excessive hunger. Every time you want to eat, which we call polyphagia. But we are going to see in general signs and symptoms of diabetes. So we have seen the differences between type 1 and type 2. Type 1, 10% in the population. Type 2, 90%. Early onset, adult onset. We have seen here it is due to complete lack of insulin, due to destruction of beta cells by the autoantibodies. Here, there is decreased levels of insulin resistance. We see here there is a probable cause which we can lead to DKA, what we call diabetes ketoacidosis. Here we have HHS, hyperglycemic, hyperosmolar state. And these are the things we can expound on diabetes mellitus. And I told you when we are looking at insulin biosensitivities, we can use C-peptide assay to distinguish between type 1 and type 2. Whatever I told you, when we do C-peptide assay, as we know that C-peptide is always the same amount with insulin. When we do it and we find this the peptide is high, it is increased, this one confirms the type 2, meaning insulin is present, but bodies are not responding. When we do C-peptide assay in the lab, and we find this one is lack, it is not there, no C-peptide, or maybe it is very reduced, then this one can confirm type 1D. These are this test you can use. So you can, apart from doing insulin assay, you can also do C-peptide assay in the laboratory to confirm. Unfortunately, the main labs here, we are not doing it. But we are the people who are supposed now to start advocating for these tests so that we can help our patients to stop treating them without knowing what is the cause, so that we can easily know the cause and we are able to combat or to target the real cause of the problem. So these are the differences which we can go. So in your free time, you can make a table and make differences between type 1 and type 2. Then we saw another important type as gestational diabetes, mellitus, gestational diabetes. And this gestational diabetes, which is number 3, gestational diabetes mellitus. This one only occurs in pregnancy. It is restricted in pregnancy, whereby you will remember that during the pregnancy there is a placenta, isn't it? And this placenta produces a hormone known as, that if we have a placenta during pregnancy, the placenta is producing what we call human placental lactogen hormone, isn't it? And still during pregnancy, we see much production of estrogen. So increased levels of human placental lactogen and estrogen produced by the placenta during pregnancy, they are the ones that are responsible for inducing insulin. These guys induce insulin resistance. They cause insulin resistance. That when they are high in saturation, even don't forget prolactin. So high levels of these hormones induce insulin resistance. That when they are high in the blood, they antagonize the action of insulin. So insulin is no longer doing this work of enabling glucose to enter into the cells. But the good news is that this type of diabetes normally clears after the pregnancy. When you produce, then this one disappears. So normally we are saying that it normally resolves after producing or after term. When you produce, the glucose levels go back to normal because the hormones which we are causing it to be high, they have gone away. Then, but having gestational diabetes mellitus, having GDM, is a risk factor. It tells us that in the future you might develop type. So it is a risk factor of developing diabetes mellitus type 2 in the future. And another thing I wanted to assure you, that in type 1 and type 2, type 1 is not genetical, but type 2 is genetical. So whenever you have family history, that in your family there is always diabetes, that one, type 2 is genetical. You find in the whole family, everyone who reaches 30 or 40, they develop diabetes, which is different from type 1. Yes. That's what I wanted also to add. So this is what I can talk about to gestational diabetes. One, it occurs during pregnancy. Number two, it is due to high production of estrogen immediately and human placental lactogen, which antagonizes the action of insulin and lead to what we call insulin resistance. That cells are no longer responding. And this one, we are saying that even when you have the lady, when it gets gestational diabetes mellitus, they are prone to developing type 2 in the future. So these are the major types of diabetes we can talk about. Then others, as I had listed them, we can see diabetes which are secondary to other disorders. Like when you have Cushing's syndrome, whereby there is overproduction of cortisol, increased levels of cortisol, that is in Cushing's syndrome. So we are on others, whereby we said Cushing's syndrome can also, so these are like the causes which can cause other types. Whereby it is not type 1, it is not type 2, but it is caused by others. Like Cushing's syndrome can lead to this, whereby Cushing's syndrome is high levels of cortisol. Then we can have, there is another condition called the pheochromocytoma. Pheochromocytoma, whereby there is increased production of epinephrine and norepinephrine. These are the major hormones we can see in causing. Then we saw it even people with insulinomas can cause another type of diabetes. Insulinomas, these are tumor cells secreting insulin. You find you have tumor cells in the pancreas which are producing insulin. So insulinomas can do that. Then even when you have any issue with the pancreas, like pancreatitis, or maybe even cancer of the pancreas, and cancer of the pancreas can also cause this, other types of diabetes. Then finally, we also talked about MODE, whereby MODE was saying maturity onset. It is maturity onset diabetes of the young. Diabetes of maturity onset diabetes, actually diabetes type 2. Maturity onset diabetes of the young, not type 2, diabetes of the. So you find you are having diabetes of the younger people, but coming it at a later age. That is what we call MODE. Then there is, before I conclude this diabetes, before I look at the diagnosis, we also know that there is a state what we call prediabetes. There's a state whereby we call it prediabetes, whereby prediabetes, meaning another term we can use is impaired. You find you are in this state of prediabetes, whereby you are not normal and you are not diabetic. So you are impaired, but we cannot confirm that you are diabetes. And this impaired, or what you call prediabetes, is whereby you have sugar levels between 7.8 to 11.1 millimole per liter. This is for postprandial. Or you have the fasting between 5.5 to 7.0. This one is for fasting. This one is what we call pre-diabetes. This is in millimoles per liter. Millimoles per liter. That is what we call pre-diabetes. So here you cannot declare someone that is diabetic, but you can do other tests like HB1C. So the tests you can do here to confirm is if someone is already diabetic, when you do RBS or you do fasting sugar levels, you can also suggest other tests like HbA1c. or you can also do what we call oral glucose tolerance test. So this HbA1c and oral glucose tolerance test can help us to confirm if these people are either diabetic or not diabetic. So when you are in a state of pre-diabetes, you can use these tests to confirm that either someone is normal or is already diabetic. Whenever you do sugar levels and you find this range. But we shall talk more on the diagnosis. Otherwise, thank you so much for listening. Always remember to subscribe. Always remember to listen to Muhumuza Naphtali videos.com, and we are always at your service. Thank you so much.